Yes. So, good evening, ladies and gentlemen. We are here this evening to understand the COVID-19 treatment options with Dr. Zarir Udwadia. Uh, Welcome, Dr. Zarir. It's such a pleasure to have you here. Um, Dr. Zarir is a consultant chest physician at the Hinduja Hospital and the Breach Candy Hospitals in Mumbai. He has struck a unique balance of combining a busy clinical practice with internationally acclaimed medical research. He sees over 10,000 patients annually in his extremely busy clinics, has over 160 PubMed indexed medical research publications, and over 7,000 citations. He has been an advisor to the WHO Geneva and helped formulate both TB and MDR-TB guidelines. In 2017, magazine Open nominated him as one of their top 25 minds for his impact on public health. He has given TED Talks on both MDR tuberculosis as well as COVID-19, both of which have been widely viewed. He's on the core committee of doctors elected by the Indian government to inform Bombay's COVID-19 pandemic response. With that very brief introduction, I will now invite Dr. Zarir to take us through this wonderful discussion, wonderful talk. Once the talk is done, we will try and see if we can take a couple of questions which he would be able to address. Dr. Zarir, over to you. Thank you very much.
Thank you, and thank you for your kind introduction. I can't see myself on the screen. Yeah, I can now. Great.
Yeah.
So in January 2020, The Lancet, which is the medical world's most prestigious journal, the Bible of the medical world, reported this cluster of 41 patients who'd been hospitalized for pneumonia in Wuhan, China. They'd all been struck down by a novel coronavirus. That report caused a stir at the time, but not the worldwide stir it has today. And from that report in January to today, 4.5 months later, we now have a global pandemic on our hands. One that has infected 4.3 million people in 122 countries. And when I last checked this morning, had killed close to 300,000 people. Indeed, we are living through an event that we seem almost powerless to stop. The novel coronavirus is the 7th coronavirus to infect man. The other 6 have been far less deadly. Indeed, 4 of them just cause common colds and no more than that. But let me tell you why I consider this particular coronavirus, the 7th, to be so devastating. For one, it's airborne and therefore invisible. It's released in droplets when a person coughs, sneezes, and more worryingly, even when he talks, hence the importance of masks, of course. It's highly infectious with a basic reproduction number R0 of 3. R0 3 means that one person will infect, in turn, 3 others, and hence the cycle continues. And that makes it far more infectious than flu. And all those of you who had someone with flu in the house and then got flu yourself will recognize how infectious even flu is. It's also 10 times more lethal than influenza. And don't forget that influenza does and will kill 500,000 people every year. It affects the most vulnerable, the most poor in society because they live in the most overcrowded areas, of course. But as you know, from crown princes to film royalty, anyone can be affected. We know that asymptomatic people can be infected. What does that mean? That means you and I, who may look and feel well and normal, may still have the infection, harbor it, and infect others, making it almost impossible to control. It can stay alive on surfaces, plastics, cardboard, metal, handles, for up to 2 days sometimes, hence the importance of hand washing. And no human has immunity to novel coronaviruses. We are all immunologically naive. We can all be infected. With those words of preamble, let me try and share my screen. And let's see if I can do this. Yes, I hope the screen is visible, and tell you what our current treatment options are today. So on the left of my screen is an electron microscopic picture from the National Institute of Health, showing you what the enemy looks like under the electron microscope. The SARS-CoV-2 virus, it's called. And the clinical disease it causes is COVID-19. So these two are almost but not quite synonymous. SARS-CoV-2 is the name we have given the virus. COVID-19 is the disease that it causes. And yes, we were unprepared when this hit us in January 2020, but do not say we were not warned, because this is the third coronavirus to cross species and ambush us in the past 2 decades. In 2002, almost 18 years ago, we had SARS caused by SARS-CoV-1, a virus which has 80% common in its genome to the present SARS-CoV-2 virus. In 2012, we had MERS, Middle Eastern Respiratory Syndrome, caused by, again, a related coronavirus called the MERS-CoV, a much higher case fatality that time, but a much more limited outbreak, which petered out in a few months. And then in 2020, we had COVID-19 caused by SARS-CoV-2. We still don't know what the case fatality of this outbreak is going to be. We believe it's close to about 1 to 5% by current figures. We know that the infection originated in a bat, which is like a factory for viruses almost, and through an intermediary host, probably a pangolin, but we can't be 100% sure. A pangolin is a scaly ant-eating mammal. Through an intermediary host, infected man. So I like this quote: a bat may infect a pangolin in Wuhan and our world shuts down, just showing you what an interconnected world we live in. Now, you're not doctors, but the 3 cardinal symptoms are put up in this cartoon: a temperature which most people will run, a cough and a cold, and you can see, of course, breathlessness, which is what this third cartoon is trying to depict. And although this disease basically unravels the lung, the assassin takes his first shot at the lung, as you can see here. We know that this coronavirus, as we have lived with it over the last 4 or 5 months and treated patients with it over the last 4 or 5 months, can literally attack any organ in the body. So if you start on the left in the topmost corner, we see strokes, confusion, delirium. We see pink eyes. In Italian patients, we saw an intriguing symptom, which was loss of smell and loss of taste, so that master chefs could not smell anymore, so that a mother who had dirty diapers to dispose could not smell the diapers anymore. So that's an intriguing symptom. The blood can be affected, and clotting problems are very common in this condition. The gastrointestinal tract, so diarrhea, the heart, an increased incidence of heart attacks, the kidneys and kidney failure, the skin and the so-called COVID toes, which are red toes, which occur characteristically in this condition, and the immune system in general. And remember that this is a virus, and a virus in a sense is like a parasite because it's unable to reproduce on its own. So that is the virus you see here, trying to enter the much bigger red human cell. And what the virus needs to enter and attack the cell is this very specific spike protein, which very snugly fits onto a receptor called the SACE2 receptor, which lines human cells, especially in the nose, the mouth, the lungs, and the gut. And then it enters the human cell, this virus, helped by this spike protein, and then basically just hijacks the human cell. It uses the human cell to duplicate itself, and then just take over the functioning of that cell, destroying the cell eventually. We have made great progress against this virus. In 4 months' time, the viral genome has been sequenced. Global cooperation has been amazing. Near instant sharing of medical advances as it occurs with my medical colleagues every morning. There are hundreds of clinical trials testing drugs and 70 with vaccines already underway, and many, many more in the pipeline. And we are involved ourselves in 1, 2, 3 different trials as we speak. And trials which normally run into months have been compressed into weeks because the gravity of the situation has been recognized by the medical community. But there is still so much we don't know about this novel virus. We don't know, for example, why some people are so much prone to get infected and to develop poor outcomes. For example, older people do very badly. Males do much worse than females. Those with hypertension and diabetes, beware because you're more likely to get hit. Those with chronic lung diseases. Ethnic factors. In the UK, for example, the blacks, the Asians, the migrants, the immigrants, what we call BAMEs, were much more likely to be infected. In fact, the first 10 healthcare workers who died in the UK trying to fight this disease were all Asians or from the ethnic communities. Genetic factors almost certainly are at play. And healthcare workers, because they expose themselves so much to this virus, are often disproportionately affected. So when it comes to drug treatment, what works and what doesn't, let me begin with a disclaimer of sorts. And that is that 5 months into this pandemic, we still have no treatment. And I'm spelling that out, no treatment that we know for a fact is effective. Hence the reliance on the 4 basic public health principles, more important than drugs in my opinion here. Testing, isolation and quarantine, tracing contacts and quarantining them as well, and in the end, extending that to lockdown of regions, cities, and in fact, entire countries, as we all know. So briefly, because you're a non-medical audience, what works and what doesn't, we have different groups of drugs which I'll run you through very simply: antivirals, anti-inflammatory drugs, chloroquine, human convalescent plasma, vaccines. And the 2 antiviral drugs we have at our disposal are drugs which were developed at the time of fighting Ebola, a much more deadly virus, but a much more localized viral infection, which you must have heard of. And these 2 drugs, remdesivir and favipiravir, have been repurposed and used and tested in this disease. So remdesivir is a 10-year-old intravenous antiviral discovered by Gilead Sciences. It's been shown to be effective against a number of coronaviruses in the past, and hence the idea to use it for the present pandemic. First used against Ebola, fast-tracked in many, many clinical trials here, quite a safe drug to be used, but can only be available on a compassionate basis in a trial setting at present, though I believe that several Indian pharmacies will be allowed to start pushing this drug into practice. The WHO has great faith in this drug. They say there is only one drug right now that we think may have efficacy, and that is remdesivir. But don't go running out to your local pharmacy because it's not available. It's extremely difficult to get. Shares in this company, of course, went up by 200% when it was hinted that this drug held promise in this pandemic. And there are several articles in prestigious journals showing that it does indeed seem to work, but not cure, not change mortality, just improve outcomes to some extent, shorten the course of the disease, reduced viral shedding in about 30% of patients, no more, who receive this drug. So not a cure, as Anthony Fauci, head of NIH, says, but certainly a promising candidate. Favipiravir, which I've got 2 patients on, again just now in Bombay, is made in Japan by Fujifilm. It's an oral antiviral. It's an experimental drug. It's not yet FDA approved, but it looks promising, and data from a Russian study just out has shown that this is safe and probably reasonably effective in the patients in which it was tried. Like any antiviral drug or any drug in any disease, these drugs must be given early if they are to have an effect. Lopinavir-ritonavir is an old anti-HIV drug, which is again now being repurposed and tried here. And it was first tried as the very first drug in this pandemic. This was a remarkable trial. Although the trial was negative, it began in Wuhan under very difficult circumstances when patients and healthcare workers were being felled by an unknown virus. So hats off to the Chinese for even attempting a trial like this. They prioritized speed over anything else. And in this heroic effort, in the midst of an overwhelming epidemic, they showed that this drug really did not sadly add much, but it is still in continuing trial even as we speak. And then the cocktail approach has been looked at recently, a combination of different antivirals, which is what you often resort to in diseases like tuberculosis, for example. And this drug cocktail of 3 different antivirals, interferon beta, lopinavir, ritonavir, and ribavirin, released a week ago in the Lancet, did seem to hold some promise. Then there are anti-inflammatory drugs, because it's recognized that some patients suffering and then dying of this condition have what is called a cytokine storm. This means that your immune system is strict and keeps raging after the virus is no longer a problem. 15% of all severely ill COVID-19 patients have this cytokine storm, often younger patients, and this may explain why young people sometimes die of this condition. It's diagnosed by finding certain markers high, of which ferritin is a tool which is available in most labs. And there are drugs which can be effective in this condition. And we have 4 or 5 patients in my ICU just now as we speak who have been given this drug. It's given as a single dose intravenously in an attempt to control this cytokine storm. And the FDA has approved of clinical trials of this drug, and all these drugs are available on a compassionate basis for desperately ill patients. The one drug that is available here and which everyone, including your aunt and uncle, have an opinion on is chloroquine, because it's a widely used anti-malarial. Hydroxychloroquine is its less toxic derivative. These drugs have immunomodulatory effects. They're old drugs as far as malaria goes. They've been used for over 50 years. They're safe and essential drugs in the WHO list of safe drugs. And they've been widely used in different conditions in the millions over the years. They're easy to manufacture. And if they were proven to be really effective, we could easily scale them up into mass treatment for the whole globe. But where is the evidence that these drugs work? Well, some of it is anecdotal, where doctors in Wuhan noticed intriguingly that patients who were on hydroxychloroquine for a number of rheumatological conditions, because that's what this drug is mainly used for, did not seem to develop COVID-19 infection. So that was the anecdotal link which had them thinking. There is good cellular evidence that this drug could be effective, and the clinical evidence is very thin and very controversial. And the first clinical evidence comes from a very controversial trial from Marseille, France, of 80 hospitalized patients who were treated with hydroxychloroquine and azithromycin, and the results seemed almost too good to be true for the medical world. Clinical improvement in 78 of 80 patients, rapid decline in viral loads, rapid discharge from hospitals. And this study was critiqued, of course, because of its small size, the fact that there was no control limb, that physicians were not blinded, that the cases were selected in a biased way, that many patients dropped out and they were not included in the analysis, and conflicts of interest, including promotion on YouTube and Fox News by authors and their colleagues, even before the article was peer-reviewed. So in my mind, a deeply flawed study which did not meet the expected standards. Of course, Trump latched onto this study full of bluster and twisted the FDA arm to quickly fast-track chloroquine for widespread release. And let's look at the words of the main author of the study, Raut, who said, to those who say we need 30 multi-center studies with thousands of patients, I say when you have a treatment that works against 0 others, this should become the standard of care. It's unethical not to administer it. But the more measured response of Anthony Fauci, the head of NIH, who said the evidence is anecdotal, had the guts to contradict his president who looks balefully on. He said the president is talking about hope. My job as a scientist is to prove that a drug actually works. And indeed, 2 subsequent studies, much better conducted, have shown that hydroxychloroquine sadly did not have any impact whatsoever on mortality. So I'm not personally very hopeful for this drug. The FDA has fast-tracked it. And my take on hydroxychloroquine is because there is nothing else to use, no other drug option available, no vaccine, it may be reasonable to use it for symptomatic patients who have COVID-19. When people talk about throwing it out for prophylaxis across the community, I feel that that data is even more scanty. Hello? It should not be used, and that should be an individual decision. Then there is this concept of convalescent plasma, which has started again in Bombay, and some of my patients have received it already. That is patients who have recovered from an infection with SARS, have already developed antibodies, can donate their plasma, donate their blood if they choose. And this is an old concept from previous Ebola outbreaks. And those antibodies, which you can see here in yellow, can be donated to a patient who's critically ill and can help the second patient make a more speedy recovery. In fact, Canada has already begun clinical trials of plasma therapy, and this is a hopeful therapy, but of course something which cannot be scaled up to hundreds and thousands of people. But bear in mind that COVID-19 is a spectrum of a disease, and many of you, 80% of you, will have hardly any symptoms at all. Only 15% will develop severe pneumonia, and 5% will develop ARDS, or what we call respiratory failure, ending up in ICUs from this disease. And then, of course, our job as doctors is to support your failing lungs, and that can be in milder cases with simple oxygen given to the nose or via a mask. In more severe cases, we can go up to 60 liters of oxygen with special devices here, which you can see. We've noticed that you can flip patients onto their stomachs, and this patient in our ICU is in the prone position, lying on his stomach, and we found that his oxygen levels improved by this simple physical measure. More serious patients, again, require a non-invasive ventilator, and here the mask is administering oxygen and air to the patient. And finally, when your patient is really bad, of course, he needs to be intubated, ventilated on a machine. Of course, vaccine is the eagerly awaited magic bullet. And already at almost pandemic speed, we have a vaccine in phase 1 studies. And getting a vaccine to the public is still going to take at least a year and a half. But this is the first volunteer receiving her vaccine. And at least we have given the first shot to the first person. But don't get your other hopes up, because you can see how long other vaccines have taken to develop, years and years. So even at 18 months, we are lucky, but that's still a year and a half away. The old BCG vaccine may have a role. We don't know as yet. And our exit strategy is unclear. Everyone asks me, when will it end? How will it end? Do we wait for herd immunity to develop? Do we wait for this R0 to fall to 1? Do we wait for antibody tests and so-called immunity passports? Do we wait for the vaccine, which will take 2 years? Or meanwhile, just follow sensible WHO exit lockdown guidelines, which are sensible, but which need really good public infrastructure. I'm going to end with this quote because it's already 20 minutes. It says, we live in evolutionary competence and competition with microbes, with bacteria and viruses. There is no guarantee that we will be the survivors. Thank you.
Fantastic. Thank you, Dr. Zarir. I think that was a superb, very quick, very interesting session. I'm sure a lot of us would have liked a little more discussion, but in the time, I think this was fantastic.
Do I have time to make a single comment, or we're through?
No, please make a comment. No problem.
So to conclude, I just want to say that history is written not only by men, but as we've discovered, also by microbes. And one thing I'm sure of is that this particular pandemic is not going to be the last you and I may witness in our lifetimes. Who knows? Maybe the next one may be even more infectious, even more lethal, so-called COVID-20 or 21. So let us be on our guard. Let us work together globally as a community and not repeat the mistakes we made in the previous pandemic. Thank you.
Super. Thank you. Thank you very much. There were a couple of questions which certainly were interesting, and I thought I'll just at least ask one question which I felt was very interesting. One, despite the anecdotal reference of hydroxychloroquine therapy, several governments, including our own government, has also recommended the therapy, both prophylactically as well as for treatment. So your comment on that?
As I said, that was based on very thin evidence. We were skating on thin ice. Some governments felt the need to be promoting some therapy instead of being honest and saying we have none which effectively works.
Right.
And the subsequent trials of chloroquine have been less than encouraging.
Right. And the last question, you did touch upon it, that there's not enough or adequate treatment, adequate evidence related to BCG. But BCG and COVID-19, do you see anything that might happen in the near future?
Well, I'm not sure. Trials are underway again, but
Okay.
this country is universally BCG vaccinated. And as you can see, the epidemic is certainly taking its toll here.
Yeah.
So it could just be an anecdotal chance hypothesis.
Yes.
It remains to be confirmed, and there are 3 trials underway.
Yes, and the last question: 5% of the population will, of the people who are infected, might end up with severe ARDS. In a city like Mumbai, Kolkata, Chennai, still possible to manage. But in rural India, where infrastructure is poor, where systems are not there, where human resources are not there, how do we really address this particular situation, sir?
Absolutely. Well, the bigger cities will be harder hit because 5% of 20 million in Bombay is still a hell of a lot.
Yeah.
In rural areas, of course, lack of facilities. And as long as you can give oxygen to these patients, the mild to moderate patients should see this disease through.
Okay, lovely. So I think in the interest of time, I will close this. Although I certainly feel there's a lot of questions, a lot of people wanting to ask. This will be a very interesting. This would be a very interesting session if it goes now on the YouTube as well. A lot of people will certainly watch it. I'm sure. Thank you very much, Dr. Zarir. I think this was a fantastic session for the day. Thank you.
Thank you. Bye-bye.
Bye-bye.